I will tell some basic aspects of cerebellum so that you understand the basis of some of the symptoms of these patients. Thank you for giving me this opportunity. As we all know, the cerebellar localization came into existence by the experiments of physiologists like Florence, Dalton, and others on animals putting lesions in the cerebellum. That started the cerebellar localization. For younger colleagues to remember the cerebellar science, there is a mnemonics that is Danish C. The D stands for dysdiadochokinesia and dysmetria. A for ataxia, N for nystagmus, I for intention tremor, speech and language, that is S, and H for hypotonia and tone-related problems, and C for cognitive function. So remember this Danish C for if younger colleagues are there, it will be easy to remember this mnemonics. So we will, keeping this in mind, we will try to correlate with the anatomy and pathology. So as we know, cerebellum is the second largest structure in the brain, and it is an information processing center for learning and programming movements and some non-motor symptoms, mainly movements that all of us know, but there are also non-movement related functions that also we should know. It's a function generator for fast movements, and it forms 10% of the total brain weight, and its volume is as much as the frontal lobe. There are, you know that we have got Purkinje cell, granule cells, and these granule cells in the cerebellum. Total count is more than the number of neurons in the supratentorial compartment. So it's a functionally very important organ. Unfortunately, we were not knowing until the animal experiments done by Dalton et al. And it is having bidirectional connections with the thalamus, parietal cortex, superior temporal lobe, and prefrontal cortex. And it balances the contractile forces of muscles and organizes complex motor activities. We know that corticospinal, corticostriate, and corticocerebellar fibers are involved in organizing complex motor activity. Corticospinal, corticostriate, and corticocerebellar. What is the role of this cerebellar is it matches the agonist, antagonist, synergist, and fixator along with the corticospinal tract. Corticospinal tract is the most important structure in forming the melody of motor activity, and this is supported by cerebellum. And it is also having a role in cognition, language, and music. So anatomically, cerebellum is divided transversely into three parts: the anterior lobe, posterior lobe, and flocculonodular lobe. I will show it in the pictures. Anterior lobe, posterior lobe, and flocculonodular lobe. And longitudinally, LARS are divided into two, vermian and paravermian. But functionally, we want to classify it into three longitudinally, that is anterior, posterior. First is anterior, posterior, flocculonodular lobe. Then vertically, if you put it, the midline is the vestibulocerebellum. I will show the picture, and it receives afferent from the vestibular nucleus. And para-midbrain is spinocerebellum. It receives afferents from the spinal cord. And the lateral part is the neocerebellum or pontocerebellum or corticocerebellum, and it receives afferents from the cerebral cortex. So these are the functional zones. Midline vestibulocerebellum receives information from vestibular nucleus. Next is the spinocerebellum. It receives information from the spinal cord. And pontocerebellum is neocerebellum or corticocerebellar connections. So this picture shows, you see, this is the anterior lobe, posterior lobe, flocculonodular lobe. Anterior-posteriorly, anterior lobe, posterior lobe, flocculonodular lobe. And longitudinally, this is the vestibulocerebellum connected to the vestibular nucleus. Spinocerebellum connected to the spinal cord, and pontocerebellum having cortical connections. These are functional zones. So this is another depiction, more simplified: vestibulocerebellum, spinocerebellum, and corticocerebellum. And anteriorly, as we have seen in the previous, this is otherwise called paleocerebellum. This is neocerebellum and this is archicerebellum. Paleocerebellum is for gait, archicerebellum is for posture, and neocerebellum is for all fine movements. And then it is having so many subdivisions. We have all learned it in our anatomy physiology classes. That is, in the center, you have got a superior vermis and the inferior vermis, and they have sub-segments: lingula, lobule centralis, culmen, declive, tuber, pyramid, uvula, nodule. So lingula, lobule centralis, culmen, declive, tuber, pyramid, uvula, nodule. You have to mug up these names, otherwise there is no other way. And in the hemispheres, you have got a frenulum, ala, quadrangular lobe, lobus simplex, superior semilunar lobule, and inferior semilunar lobule, biventral lobe, and the cerebellar tonsil. So these are the subdivisions of the cerebellum. And the cerebellum has got nuclei. This is the dentate nucleus, which belongs to the neocerebellum. And we have got the nucleus intrapositus, that is emboliformis and globosus together are called nucleus intrapositus, that belongs to the paleocerebellum, and this is the vestigial nucleus which belongs to the vestibulocerebellum. So as I said, the nuclei, each nuclei is linked to one's intrapositus, emboliformis, globosus. Dentate is in the neocerebellum, vestigial in the archicerebellum. And it is having peduncles, all of us know superior cerebellar peduncle, inferior cerebellar peduncle, and middle cerebellar peduncle. And median vermis has got the so many lobes which I just described. And this is the sagittal section, what we see in our imaging. So there we can localize, this is the anterior lobe, this is the posterior lobe, and this is the flocculonodular lobe. Here you can see the flocculonodular lobe. This is the dentate nucleus, vestigial nucleus, and emboliformis and globosus. So cerebellum is only as good as its inputs and outputs, because we saw that it is an information processing center for learning and programming movement. So it has to learn about what is the body parts like now, and then it will have to program and carry out the desired motor activity. So it has to be connected. So cerebellum is as good as its inputs and outputs. And in order to coordinate this, what are all the information needed? What the brain wants the body to do. When a lion is coming, what should the body do? So what the brain wants the body to do. And where is the body in space? Are you closer to the lion or away from the lion? So these are the two information needed so that cerebellum can form the motor schema. For that, we have got the peduncles. One is the middle cerebellar peduncle, which carries information from the cortex through the cortico-pontocerebellar fibers to the cerebellum. And this is the inferior cerebellar peduncle, which carries fibers which are telling the cerebellum where is the body in space. Just now I told that we should know where is your body in space and what the brain wants the body to do. These two things. For to know where is the body in space, inferior cerebellar peduncle carries all the information about the head and neck and body parts of the cerebellum, and so cortex decides what kind of movement to be done, and what is the formula made by the cerebellum is conveyed to the cortex through the superior cerebellar peduncle. So superior cerebellar peduncle conveys to the cortex the motor plan, and the motor cortex conveys to the cerebellum to the activity to be carried out, and inferior cerebellar peduncle carries information regarding what is the position of the body in space. So this is another picture showing the main connections of the superior cerebellar peduncle. We know that it is the olivo-dentato-rubro-thalamo-cortical pathway. That's the most important different pathway in the superior cerebellar peduncle, olivo-dentato-rubro-thalamo-cortical, that can be split into various levels. And the afferent is ventral spinocerebellar, but mostly superior cerebellar peduncle, the efferent is the most important one. And in the middle cerebellar peduncle, it is having only one pathway, that is cortico-pontocerebellar. And inferior cerebellar peduncle, it is having many connections because it has to convey to the cerebellum the position of the head and neck, body, eyes, limbs, everything to the cerebellum, so that cerebellum can decide what movement has to be carried out. These afferents come from the vestibulocerebellar, cuneo-cerebellar, nucleocerebellar, reticulocerebellar, olivocerebellar, arcuatocerebellar, and dorsal spinocerebellar. So all these tracts give the cerebellum information about various body parts in space. And this one will tell what is to be done to run away from the lion. And this will tell what is the plan that the cerebellum has made to coordinate the agonist, antagonist, synergist, and fixator, so that we can run correctly and not run towards the lion. So this is the way cerebellum plans motor activity. So this is what I told about the inferior cerebellar peduncle. The vestibulocerebellar fibers give the information regarding the position of the head in space. And the spinocerebellar tracts where is the body in space. And olivocerebellar is for motor learning. That is, we say that whenever the body parts are swaying and all aligned, so many other systems are acting. So vision will see that the body is not aligned properly with the lion. So what will happen? The image will slip on the retina. We just want to see where exactly is the lion so that you can run and escape. But when you are not properly aligned, the image of the lion will slip on the retina. That is called retinal error. This retinal error will be sensed by the olivocerebellar pathway and informed, so that exact connections, calculation to know how to fix on the target and make the motor plan will be made. That is the inferior cerebellar peduncle. The middle cerebellar peduncle conveys information about what the brain wants the body to do. It is the cortico-pontocerebellar pathway. Superior cerebellar peduncle, as I told, it communicates to the brain what plan the cerebellum has made. And it exists from the cerebellum by way of the upper pons, then crosses at the junction of the upper pons and the lower midbrain. And some cross fibers synapse with the red nucleus, contralateral to the cerebellar hemisphere of origin. And others continue into the ventrolateral nucleus of the thalamus, contralateral to the cerebellar hemispheres. So that is olivo, dendato, rubro, thalamo, cortical. That is the most important pathway. We always tell that cerebellum, like if you take motor cortex, the signs are on the opposite side. Internal capsule, opposite side. Occipital lobe, contralateral hemifield. But for cerebellum, it is ipsilateral. So in the examination, people will ask why cerebellar signs are ipsilateral. And we always start to tell a standard answer because of double crossing. What is that double crossing? So that is cortico-pontocerebellar. That is one crossing from the cortex of the left side through the pons of the left side. The fibers cross over to the right-sided cerebellum. From the right-sided cerebellum through the olivo-dendato-rubro-thalamo-cortical pathway, the fibers go back to the left-sided cortex. So this double crossing cancels each other so that dysfunction manifests unilaterally. So this is double crossing, cortico-pontocerebellar crossing onward and olivo-dendato-rubro-thalamo-cortical crossing backward. These two double crossing makes the dysfunction unilateral, ipsilateral. So the corresponding nucleus of each zone, midline is linked to the vestigial nucleus, intermediate part is linked to the globosus and emboliformus, and lateral part is linked to the dendate nucleus, and vestibular zone to the vestibular nucleus. So now we will see vestibulocerebellum. What is that? The flocculonodular lobe. The posterior part of the cerebellum is otherwise called vestibulocerebellum or archicerebellum. It's a very old part of the cerebellum, and it is in control of body posture and equilibrium. Because vestibulocerebellum, the vestibular nucleus gives information regarding the head on body. So that helps to correct the body posture. So vestibulocerebellum or flocculonodular lobe is for body posture and equilibrium, and the nucleus concerned is vestigial nucleus and the vestibular nucleus. Spinocerebellum, the second zone. It includes part of the paleocerebellum, the anterior part of the cerebellum, the entire anterior lobe, except the uvula, except the nodule and uvula and paraflocculus. And the nucleus is emboliformus and globosus. and it is concerned with the spine, limbs. Whereas vestibular cerebellum is head and neck and body posture. Spinocerebellum is limbs. Then corticocerebellum consists of the posterior lobe of the cerebellum, which I just showed you, except the part constituting to the paliocerebellum, and its nucleus is dentate nucleus, and it is concerned with smooth performance of highly skilled voluntary movements. And then come to the nuclei. So we saw the archicerebellum, neocerebellum, paliocerebellum. Paleo is for vestibular cerebellum, is for head and neck correction. Spinocerebellum is for body. Neocerebellum is finely tuned movements. And the vestigial nucleus, because it is linked to the vestibular cerebellum or archicerebellum, again it is extended function of stance and gait. Interpositus and emboliformis, it is stability stop for unwanted movement. That means supposing you carry out a movement to reach a target. On reaching the target, we have to stop the movement. So the activity should not continue beyond that. To stop the movement, what is to happen is activate the antagonist. So on reaching the target, to stop the antagonist, to activate the antagonist and stop the agonist, interpositus and emboliformis is helping. So they are called stability stops for unwanted movements or checking reflex. And dentate nucleus assists task needing fine dexterity and range, fineness. That is dentate nucleus. Interpositus nucleus is responsible for the rebound phenomena. When it is defective, the antagonist will not be activated, so rebound will happen. Then histology, not very relevant for us in this clinical setting. Outer molecular, middle Purkinje and inner granular layers, and the vessels which supply are superior cerebral artery, posterior inferior cerebral artery, and inferior cerebellar artery. And we have got the massive fibers which carry information from the whole of the brain regarding spatial memory to cerebellum, and climbing fibers processes the retinal error signal, which I just told. When you are focusing on a target, retinal error is important for making the motor activity to correctly fix, run, fight, all those things. You should know where is your target and where are you. For that, retinal error signal processing is done by the climbing fibers, and massive fibers is connection to the whole of the cortex. So now we have seen grossly the anatomy, including the nuclei, the peduncles, and their functions and physiology. So to summarize, what is the function of the cerebellum? It is concerned with rate, range, rhythm, direction, amplitude of both motor and cognitive functions. Not just motor, it is also having role in cognitive functions. And it is having excitation of antagonist and inhibition of agonist at the end of the movement. That is what I told, checking reflex mediated through nucleus, interpositus and emboliformis. And it retinal error, so visual sensation. So it is linked to sensation, intellect. And the Vermean zone is concerned with positional adjustments of eye and the head, and para-Vermean is for the skilled movements and automatic movements. So this is again, and the continuation of summary: archicerebellum, vestibular and eye control; paliocerebellum, muscle tone, axial control and stance and gait; and neocerebellum is for planning, fine motor movements of upper limbs, eyes and speech; and anterior lobe is motor dominant, posterior lobe is cognitive. This you remember, anterior lobe, that we found the part of the cerebellum anterior to the great horizontal fissure. That anterior lobe I showed you in the sagittal cut as well as in the picture of the cerebellum. The posterior lobe is for cognition and anterior lobe is for motor functions. What is cerebellar glomeruli? If you are having, if MD students are there in this group, it is a short notes. So cerebellar glomeruli is the ultimate functional unit. We saw the cerebellum controls so many things, and what each tract is doing everything, but it has to take place at a subcellular functional unit, and that unit is the cerebellar glomeruli. It is formed by a massive fiber which carries information from the whole brain, granule cells, and axon, and you have got the granule cells and their axons and dendrites, and also it receives afferents from the spinal cord, brainstem, subcortical nuclei, and difference to the extracerebellar destinations. So this cerebellar glomeruli coordinates all the information received. It maintains the sensitivity of the muscle spindle, and it is controlling the agonist, antagonist energy. Ultimate control is taking place in the cerebellar glomeruli. And what are the electrical activity in the cerebellum? Haptic signaling. It is for ultimately cerebellar output is inhibition. So that net output is inhibition, and that is by conduction by contiguity. That is haptic signaling. Spontaneous firing in response to information received, and synchronization of all this information, and that leads to motor learning by LTP. And we all know about the motor functions, but non-motor function is a new concept. And just like the rate, range, rhythm, direction, and amplitude of motor activities controlled by the cerebellum, same of the cognitive, language, and emotional function is also done by the cerebellum. The evidence is changes in cerebellum seen in patients with the major mental illnesses, autism spectrum disorders, Down syndrome, and mutism in children following cerebellar surgery, and transcranial magnetic stimulation and its role in treatment of schizophrenia symptoms, sham rage. So all this indicates that there is some neuropsychiatric link for the cerebellum. When there is recording in conscious animals regarding motor activity shows that when the dentate nucleus and its cortex is stimulated, 3 types of discharges happen. First discharge produces the inner motor map or intention. So what the cerebellum wants to do. That is the superior cerebellar peduncle connections will convey to the cortex, I have just told it. And that inner map is prepared by the cerebellum in response to information received. And this next thing to be activated is the various muscles which are to be recruited. And third activation is the joint position. So motor map, then muscles are recruited and joint position is planned. And planning is taking place in the lateral lobe. And dentato-thalamocortical pathway carries it to the cortex. Nucleus interpositus and that is intermediate emboliformis and globosus is through the secondary status monitoring, that is stopping at the end of the activity. And spinal cord and nucleus, when the information regarding body parts to be moved is from the spinal cord, interpositus nucleus becomes more important than dentate nucleus. And we have got various neurotransmitters which carry out these functions as a cell-to-cell transmitter. So this picture shows the cerebellar homunculus. This is very useful for our younger girls and boys. This is the paleocerebellum, where you are seeing only the leg. So only it's a 3-monkey homunculus. Only the leg is in the paleocerebellum. So when the paleocerebellum is affected by disease process, only gait ataxia. We learned that it is controlled with axial tone. Just now I mentioned it. So this is affected, nothing else will happen, only gait ataxia. This is the neocerebellum. Here you can see that the eyes, head and neck, upper limb, eyes, head and neck and upper limb of all the 3 monkeys are in the neocerebellum. So in neocerebellar disease, upper limb incoordination, nystagmus, speech, all this will be affected, and posterior lobe is linked to cognitive functions because of the head and neck is also there. And this is the flocculonodular lobe, the leg is there. So this also will produce gait ataxia, but it is linked to the vestibular nucleus. Because of that, vestibular type of eye movement will happen. So that differentiated from the paleocerebellum. Paleocerebellum is only leg, gait ataxia. Flocculonodular lobe or archicerebellum is leg plus vestibular connection. So eye signs plus gait ataxia is flocculonodular lobe. So this is making it simplified. Leg is in the paleocerebellum, upper limbs and head and neck, eyes in the neocerebellum. So cognition, eye signs, upper limb signs, speech, and then you have got the lower limbs in the flocculonodular lobe with vestibular connection. And all the trunk structures are in the vermis. So vermis will produce truncal ataxia. Next, we will come to the cognitive functions. That is carried out through the, we saw the 3 peduncles mainly motor activity. Cognitive circuits are cerebellar circuit from the cerebral cortex through the brainstem to the cerebellum and back to the cortex. So this is cerebellar circuit. Then this is the bidirectional circuit between the cortex to the cerebellum and cerebellum back to the cortex. These are all cognitive circuits. Then you have got a frontocerebellar circuit from the frontal lobe through the thalamus, pontine nucleus to the dentate nucleus cerebellum. That is for attention and executive function role of cerebellum carried out through the frontocerebellar circuit. And procedural memory circuit is by cerebellum's connection to the inferior parietal lobule. And that is a polymodal association area. And episodic memory circuit is by cerebellum's connection to the lateral temporal lobe. So what are the cognitive functions? We grossly saw the motor functions. And then Danish C, that C is cognitive function. Posterolateral regions are for cognition and consciousness. And worm is for affect. Language function is in the right cerebellum. The small boys and girls should note that left cerebellar cortex, but right cerebellum is for language function. And there are feed forward and feed backward circuits with the parietal lobe, temporal lobe, frontal lobe, and paralimbic area. So that again has a role in cognitive functions. Because the posterior cerebellum is the cognitive lobe, we saw the homunculus where the head and neck is in the posterior lobe of the cerebellum or the neocerebellum. Because of that, superior cerebellar artery, which is supplying the anterior lobe, does not produce cognitive deficits. But vascular disease involving the posterior lobe of the cerebellum produces more cognitive deficits. And somebody has now observed that there is also a role for cerebellum in recognizing facial emotions. We know that it is in the facial or gyrus in the medial occipital region, but now some functions are being attributed for face recognition also, but exact circuits are yet to be determined. So now, I have grossly given you a gist of anatomy and physiology of motor and cognitive functions of cerebellum. If you go through these PPTs once again, it will all become very clear. And disease happens due to various causes. It can be acquired or it can be genetic, we know. It can be channelopathy, it can be due to accumulation of neurotoxic materials, or it can be enzymopathies, or it can be unknown mechanisms, and it can be a signaling disorder, DNA repair disorder, cellular energy failure. So many group of disorders can lead to cerebellar disease. So now we will remember the mnemonics again, what I have told, and we'll go one by one. So what is this first D? Dyssynergia. So we just now we saw anatomy and the physiology. Now we are going to pathology. So what is meant by dyssynergia? Dyssynergia is voluntary movement takes longer to start and stop. So slowly it happens because rate, range, rhythm, direction is controlled by cerebellum. Yeah, so fast movements means it has to be controlled very properly. If you do slowly, you can do the use the corticospinal and the corticostriate pathway visually guide the limb. So movements are made slow to adapt for a failure in the fast movement. And outstretched arm overshoots and oscillates around the point. So these are manifestation of dyssynergia. So first is dyssynergia because rate, range, rhythm, direction, amplitude is controlled by cerebellum. When cerebellum is sick, all these become difficult. So corticostriate and corticospinal pathways with the help of vision slowly carry out. So movements take more time to start and stop. And when it reaches the target, it is not exactly antagonist or not activated. So it will oscillate around the point and it will either overshoot or undershoot, and rapid alternating movement, which involves proper control of rate, range, rhythm, becomes defective and clumsy, and they will have pronation, supination movements, slide through a larger amplitude, and movements lose their fluency and become broken. That we call it a decomposition of movement. So under D, we have got dysdiadochokinesia, dysenergia, dysmetria, and decompositional movement. So the D will manifest as dysenergia, dysdiadochokinesia, decompositional movement, and all these come under the D. Next, what is this decompositional movement? So when you have to carry out a movement, we quickly do like this. Instead, it becomes, that is, each movement becomes broken into small movements. That is decompositional movement. Acceleration and deceleration, duration is prolonged because fast movement, it's a function generator for fast movement. I have told all this in the anatomy. Let to go through is one. So acceleration and deceleration becomes prolonged, and acceleration phase of RAM movement also gets affected. So acceleration phase gets affected whether it is a ballistic movement or a RAM movement, and start and stop is delayed, though velocity as such is not altered. And this is due to fine-tuning defect by dentate and its connections. Next is dysmetria. Dysmetria is reflected in difficulty with both simple and complex movements. So it's a trajectory disturbance. So when you have to reach exactly the nose, it will either overshoot or undershoot. So dysmetria is, dysenergia is breaking down. Dysmetria is on reaching the target, there is a trajectory disturbance, so that it overshoots or undershoots and falls short or fall beyond the goal. And movement initiation and termination is also affected, and the pathology is in the dentate nucleus and is connection resulting in central programming defect clubbed with hypotonia. Next is dysdiadochokinesia. Rhythm. So it's a rhythm, it's a disorder of rhythm, alternating movement. So I have given in the summary what is the function. You should go back, then you know it's a rhythm disorder. When you have to do a rhythmic activity, it becomes clumsy. After two pronations, it may be, instead of doing one pronation and one supination, two pronations, one supination, or two supinations, one pronation. So that is dysdiadochokinesia. And rebound phenomena. All of us do all these things. When the patient is told to outstretch the hand, and you just press it down, it will rebound because antagonist activation to check the movement is defective. We just said that it is interpositus and emboliformis. Similarly, we tell the patient to keep it flexed and then pull it. But the problem is when there is a rebound, they can hit their face. So better method to do like this and push down. So injury to the patient's face does not happen due to rebound. Next is ataxia. So ataxia, what is balance? The ability to maintain body parts in desired alignment, in balance with the gravitational pull during rest and activity. During rest is posture, and during activity is equilibrium. And the ability of the organism to displace from one place to another is movement. And it involves so many phases that we have discussed in some cases when we discussed the patients with gait abnormality. The role of cerebellum is in maintaining the last two components, that is equilibrium and propulsion. And so gait is like the signature of the neuraxis. We know that each personalities, normally also, there is so many changes, ways of walking by which we know this person is a quiet person, introvert, extrovert, grandiose person. All those things we know by the gait of the person, and in disease also, it gets altered. And you will have to check the patient's gait in different phases. These also we have discussed in cases of sit, stand, walk, run, climb up, climb back. So all these things should be done to assess the gait. And this picture shows the gait cycle. As we know, the gait starts with the heel strike, and the cycle ends with the heel strike by the same leg. Starts with the heel strike of one leg, and the cycle ends with the heel cycle of the same leg. It consists of a stance phase, that is stance phase. Then swing when the arm is swinging and the leg is swinging, and you have got a bipedal phase. So stance phase, swing phase, bipedal phase. And ataxia is a middle level gait disorder. It's a disorder of control of force and timing of movement. And whatever ataxia happens, always remember any bizarre movement, we should not call it as ataxia. When you walk forward, cerebellar disease will produce a perpendicular swing. So when you are moving anterior-posteriorly, cerebellar thing will be like this. So perpendicular to the plane of movement. Whatever movement the person is doing, the swing will take place perpendicular to the plane of movement. And there is abnormal functional stress reflex, and there is variability in stride length. We saw the gait cycle. It's beyond 1 hour talk, so just giving the template only. So as we just saw, I am repeating so that it gets fixed in the younger colleagues. Rate range, so variability in the stride length and range, so the veer to either side, and trunk space. So when this is happening, to adopt to all these abnormalities in motor activity, get the broad base. So broad gaze gait in cerebellar disease is not a manifestation of disease. It is a manifestation of compensation by the other structures which are normal to make the patient move comfortably in the face of a variable stride length, swaying to either side, and strangle ataxia. So when all these things are there, till the patient has to move forward means the base has to be broad. That is what happens in broad-based gait of cerebellum. Is a compensatory mechanism, not sign of disease. Disease is altered stride length, swaying perpendicular to the plane of movement, and triangle swaying. So it's a middle level gait disorder. Gait disorder is classified into lower level, middle level, and higher level. Cerebellum produces a middle level gait disorder. So how to differentiate cerebellar from sensory? Always these questions are asked in the examination. Cerebellar disease, I said it is perpendicular to the plane of movement. You are moving forward, you sway sideways. And rhombox is negative, broad base, turns and tandem walking is most affected. Whereas sensory is a bizarre gait. That is not perpendicular to the plane of movement. It is because you do not know where is your leg or where is your body. Due to sensory deafferentation, we do not know the position of the body. So the gait becomes very bizarre. Rhombox and wash basin sign is present. Broad base is of course shared. There can be pseudoathetosis. That is, tell the patient to stretch the hand. He will try to know where is his body. So he will search it with this kind of movement. That is called pseudoathetosis. Similarly, in the leg, the patient will try to explore the earth with the toes. So that is called damp detendant. And then still they are unable to judge the depth. So they carry a stick and hit the floor with a stick. And still when the stick is removed, they forget the space. So bring down the leg with a stamp. So it's called stick and the stamp gait, not a broad-based swaying gait. And eyes are fixed on the floor. And the gait worsens when the light is taken off. Next, we will come to the nystagmus. So cerebellum, various structures. I have taken 1 or 2 sessions on eye movement. I have not completed it. I think I took 2 sessions on eye movement control. So these various structures control the eye movement. Each one we will not elaborate. And in cerebellar disease, we get skew deviation, gaze evoked nystagmus, periodic alternating nystagmus, square wave jerks, and cogwheel pursuits. These are the N. Danish N is for eye science nystagmus. So impaired amplitude of the saccade causes saccadic dysmetria. When you tell a saccadic movement to fix at a target, it overshoots or undershoots. Impaired gaze holding causes gaze evoked nystagmus, and pursuits are broken. So these are important features of cerebellar disease. And so eye signs as a clue to bedside diagnosis. Square wave jerks, these are saccadic oscillation in straightforward gaze. If that is there in a patient with cerebellar disease, you can think that this patient may be having Friedreich's ataxia. There are so many criteria, but eye as a clue is square wave jerks if present, it may be Friedreich's ataxia. Gaze evoked nystagmus, any neocerebellar disease. Hypo or hypermetric saccades, any disease of the neural integrator. Neural integrator is 3 neuron arc, cerebellum, PPRF, and perihypoglossal nucleus in the pontomedullary region. Then saccadic pursuit. When you tell a saccadic movement, follow-up movement, slow follow-up movement. Instead of slowly following up, patient will produce multiple saccards. So saccadic pursuit is seen in SCA3, spinocerebellar ataxia 3. Whereas slow saccades, you tell the patient to do a quick movement, he will slowly reach. That is SCA2. And oblique saccades become abnormal in Whipple's disease. Ophthalmoplegia and Polg mutation, that is mitochondrial disease. Upgaze palsy in Niemann-Pick's disease. And horizontal gaze palsy in Gaucher's disease. All these people have features of cerebellar involvement. And these kind of eye signs, if they are present, it gives a clue to the clinical diagnosis. So this is a Q deviation. What is Q deviation? Q deviation is vertical, this thigh is down, this eye is up. So vertical disconjugation of thighs due to a supranuclear cause. That is called Q deviation. Vertical disconjugation of thigh due to a supranuclear cause, Q deviation. What is square wave jets? Horizontal saccadic intrusion seen in straightforward gaze. It interferes with macular fixation. It has only fast components, slow components not there. So that is very useful in diagnosing Friedreich's ataxia. And other eye movements, flutter is saccadic oscillation without intersaccadic interval. Opsoclonus is conjugate chaotic multidirectional eye movement. And you can get hypo or hypermetric saccades. This picture shows straightforward gaze. You are having movements which are faster, they are not perceived movements. To remove maxillar fixation. Remove the object from maxillary. This is chaotic multi-directional. Just watch it. This is an acute cerebellitis. The patient will have attack. The eye signs usually seen in viral disease. Sometimes we can find it in malignancy. Paraneoplastic. You see that eyes are having multi-directional conjugate eye movements.
Straight रखना है. इधर ऊपर देखो. इधर देखो.
You can see that eye is moving in multiple planes, but they are all conjugate movement. This is patients can have dementia, ataxia, Parkinsonism. It's an infectious disease. Oculomastigatory myorrhythmia, very diagnosis of Whipple's disease, where the oblique saccades become affected, but that cannot be demonstrated at the bedside. Only with the electron nystagmograph we can demonstrate, and this kind of movements, because it is responsive to antibiotic treatment. It's an infectious cause. So, oculomastigatory myorrhythmia. This is very classical of Whipple's disease. So now we will see how are you going to differentiate the eye signs in cerebellar versus vestibular. It's a gaze evoked nystagmus due to leaky neural integrator. So what do you understand by that? When you look to the right, the fast component of the nystagmus will be to the right. When we look to the left, it will be to the left. So that is gaze evoked nystagmus. It is never seen in straightforward gaze, and it is due to neocerebellar disease. Whereas vestibular nystagmus is due to disorganization of the push-pull mechanism in the semicircular canal. So this I have put it in the when I gave my talk on eye movement control. I think in the first session I have told about this. So various semicircular canals are linked to a pair of muscles. When it is destroyed on one side, the eye will move towards the diseased side. So this is not gaze evoked the eye will be pushed towards the side of disease. And it will have a rotary component. And how it happens, I had explained it. I cannot, that much time will not be there for this. This is there in my previous talk on eye movement control. You can see that anterior canal, it is superior vestibular nucleus, ipsilateral superior rectus. Superior rectus is an elevator. And contralateral inferior oblique. Inferior oblique is an elevator. Superior muscles are intorters. Inferior muscles are extorted. So this is the connection of the anterior semicircular canal. Posterior semicircular canal, ipsilateral superior oblique, contralateral inferior rectus. Then this horizontal is contralateral lateral rectus, ipsilateral medial. So one side is damaged in this patient. Let us imagine. So this side is damaged. This depression and this elevation will cancel. This depression and this elevation will cancel. Horizontal, there is nothing to cancel. Here there is intorsion, here there is extorsion. So torsion cannot cancel. So the nystagmus will show deviation of the eye towards the side of disease with a torsional component. Vertical component will not be there. Unlike the gaze holding defect or the pulse step mismatch in cerebellar disease, here it is an imbalance at the level of the extraocular connections of the semicircular canals. That results in a nystagmus with a horizontal component towards the side of disease and a torsional component. So you can just go back and see my eye movement session, and then it will become more clear. So cerebellar disease, as I said, is leaky neural integrator. Pulse and steps should be matched. Supposing I want to look at an object, I should generate a pulse to reach that object. How much time I should stay in that object so that I am able to study there. So there is a match. This pulse step match is not there. So what happens? Pulse is there, and once the target is reached, it's not able to stay there. So it comes back. That is a gaze-evoked nystagmus of cerebellar disease. Vestibular, I just explained push-pull mechanism at the semicircular canal. Next, we will come to hypotonia, that is tone control. So spinocerebellum regulates the postural reflexes by modifying the tone. Spinocerebellum is the paravermian part of the cerebellum. It facilitates the gamma motor neurons of the spinal cord via the cerebrovestibulospinal and cerebello-reticulospinal tracts. And that determines the sensitivity of the muscle spindle. All of us know there is an intrafacial fiber. The intrafacial fiber is having gamma motor neuron connections. And this gamma motor neuron will decide when the muscle is stretched, at what point it will activate the extrafacial fiber. So the alpha motor neuron will activate the extrafacial fiber. And at one point the muscle will break. So at what point it contracts and activates the extrafacial fiber is called the sensitivity of the muscle spindle. That is done by the cerebellum. So gamma motor neurons reflexively modify the activity of all other motor neurons and regulate muscle tone. So at what degree of stretch the extrafacial should contract. Extrafacial is by alpha motor neuron. So this is called alpha gamma coactivation. So cerebellar glomerulus is the site of alpha gamma coactivation. In cerebellar disease that fails. Yeah, so alpha, because the gamma motor system is failing, the gamma motor system's modulatory effect on the alpha is not there. Because of that, the alpha motor neuron, which is concerned with the motor stretch reflex, remains unaltered, whereas tone becomes altered because of the failure of the fusi-motor or the intrafacial fiber function by the gamma motor neuron. So that is why in cerebellar disease, we get hypotonia, but reflexes are not altered. This combination of hypotonia plus hyperreflexia is called as alpha spasticity. So cerebellum, we know, produce hypotonia, but unlike a lower motor neuron disease where hypotonia will be there, you check the reflexes are preserved in this condition because the alpha gamma coordination fails in favor of alpha. Alpha is no more modulated by the gamma, so it remains its stretch reflex. Whereas fusi-motor connection is imbalanced, so tone becomes altered. This unique combination of hypotonia and hyperreflexia is called as alpha spasticity, which is seen in cerebellar disease. Then we will come to the cognitive consequences: emotional blunting, depression, disinhibition, sequencing and planning disorder, impulsive and poor attention, because we saw the various circuits which connects the cerebellum to the various cortical areas. And the classical syndromes of cognition are cerebellar cognitive affective syndrome, posterior fossa syndrome, apathy, aphasia, panic syndrome, and cerebellar aphasia. These are the 4 classical syndromes of cognitive dysfunction in cerebellar disease. If you have MD students or DM students, it is important. For undergraduate students, this is not very important. So cognitive, cerebellar cognitive affective syndrome, posterior fossa syndrome, apathy, aphasia, panic syndrome, and cerebellar aphasia. So how are you going to test at the bedside? We have to note the position of the limbs, body, head, and trunk while sitting, standing, and walking. Look for titubation, wobbling of the trunk, broad base, swaying, reeling, and look for subtle ataxia by turns. When you bring a case, we can discuss all these elaborately. Here I will only mention. So do tandem walking, Barani's chairs, or walking around the chair, Fakuda stepping, and Babinski is walking on parallels. In some cases, we have discussed all these signs. So that I will tell you. In case some of the volunteers are taking cases, we can see all this. Then we have got ocular dysmetria by doing command movements. You tell the patient to look at 2 targets. He will either overshoot or undershoot. You sit in front of the patient to give 2 targets. And when he shifts between one target to another, he will either overshoot or undershoot. The impaired smooth pursuit. And the test, collectively, the test of eye signs are called HINS test. This head impulse test, that is to look for the vestibular gain. Then nystagmus and the skew. These 3 are important things to be tested in NIMHANS. Together, it is called HINS test. So HINS test, to look at the, you tell the quickly move the eye laterally when the patient is told to fix at the nose. If the VOR is all right, patient's eye will not move. When you are moving the head to one side or opposite side, if the VOR is intact, the patient will be able to maintain his gaze on the target on which you have told him to do. That is head impulse test. And you can look for gaze evoked nystagmus, upbeat nystagmus in vermis, downbeat nystagmus and uvula and nodule lesion, and rebound nystagmus. While turning from eccentric gaze, suddenly the slow position of the nystagmus, which is gaze evoked, normally gaze evoked. So when you're looking to the right, the nystagmus will be fast to the right. But you just keep waiting for some time, then the to that side, slow component comes and fast component moves away. That is called rebound nystagmus. And you can look for skew deviation if it is not obvious by doing alternate cover test. This also is mentioned in my eye movement talk, that will be there. So I'm not explaining the cover test. So downbeat nystagmus and nodule will produce periodic alternating nystagmus. What is alternating nystagmus is beating to one direction for 2 to 3 minutes and spontaneously changing the direction and moving to the opposite side. So it is spontaneous, changes direction every 3 seconds. Slow phase is affected, so only fast phase remains. It is supposed to be due to poor synthesis of vision, optokinetic nystagmus, and VOR together to produce a normal gaze. So this synthesis of all these 3 phenomena fail in cerebellar disease, resulting in periodic alternating nystagmus. Then we will come to speech and language. That can be, you know that you have got the staccato speech, scanning speech, which can be in the spontaneous speaking, or you can put various muscles into activity by telling the patient to pronounce different kinds of words, ah, la, me. So for the lip muscle. So, and each muscle will check the speech expression through the various muscles. So that can be tested like that if it is not obvious when the patient is doing spontaneous speech. So there is irregular in force. In bringing out words, there is irregular force. Words are broken into syllables and there is unnecessary hesitation. That results in scanning. And undue acceleration results in explosive character. Music, as we know, that there is a ragam and a talam. Talam is the timing. So in cerebellar disease, rate, range, rhythm, direction, the same thing only gets affected in everything. So when the rate, range, and rhythm is affected, the timing of the thalams become defective. So your thalam defect happens with reference to music. So right cerebellum is for language, and that presents with word finding difficulty. Sequencing and planning of spoken language become defective, and left cerebellum is for prosody, which is the opposite of hemispheres. Then in the upper limbs, all of us do the finger nose test, finger nose finger test, and that is next you have got the you have to chasing the finger means the examiner instead of keeping his finger in one place, first here, then here, he keeps on going to make the test more complicated. That is called chasing the finger test. Then look for rebound phenomena, posture maintenance, and tone by passive shaking or keeping the limb like this, hypertonic limb, it will fall down. So you look for tone changes and finger, nose, finger alternating movement. That is a finger chase test is examiner keeps on changing the position of the finger to bring out a subtle finger nose incoordination. Then adidacokinesia, all of us know that we have to do repetitive. All these clinical science to study. This is a theory when I talk. When students have cases, we will do. You can do it on the thighs, alternate, or on the opposite hand, and give a wider range. If you are putting on the thigh, the patient can lift the hand up to the chest level and slap like that or do like that. And that rhythm cannot be maintained. That is adidacokinesia. And in the lower limbs, resting, how they stand, we have got the heel knee test, heel shin test, and subtle turns. Look at the turns. And look for subtle imbalance by stand with the feet together, stand with tandem stance, and stands on either feet, hop on either feet. All these can be done to bring out subtle imbalance. Then you look for titubation and tremor, head movements. You get titubation in the anterior vermis lesion, and you get intention tremor is the classical cerebellar tremor, it's a dysmetric tremor. And in essential tremor, it is believed that we know that hypertrophic degeneration of the inferior olive. One. Second, there is cerebellar stimulation is supposed to be one treatment option for essential tremor. So is there a cerebellar hyperactivity? That is a postulate for essential tremor. And so now we'll come to what are all the functions in motor learning and cognitive learning by cerebellum. I am just summarizing. Automatization of motor sequencing. You do a typing movement. It has got a sequence. So that corticostriate, corticocerebellar, and corticospinal. These three tracks together, of course, it is not a focused one track function. So automatization of motor sequencing, eye blink conditioning, vestibular reflex adaptation, and non-motor tasks like procedural memory, where we have got supplementary motor area, basal ganglion, cerebellum. That is procedural memory, driving a car or swimming, that kind of thing. And learning serial reaction time task. So time planning becomes defective. Then procedural learning and cognitive association learning task. That is cognitive thinking, how much time, mental slowing. So when it is defective, mind processing time becomes more, otherwise called mental slowing. Affective, we saw even various kinds of emotions by the various cortical connections become affected, and you have got abnormality of cerebellum in conditions like autism, ADHD, as well as schizophrenia. So what is the cerebellar cognitive affective syndrome? So ability, they have got poor executive function. They have got spatial cognition defects. So visual spatial memory becomes impaired. language defect in the form of agrammatism and episodia, and they have got personality change. This together is called cerebellar cognitive affective syndrome, seen in posterior lobe of the cerebellar disease. Posterior fossa syndrome, following medulloblastoma surgery, suddenly the person becomes mute in the post-operative period. It is said that cerebellum has got linked with the subcortical or Mary's quadrilateral space. That becomes functionally suppressed. The motor schema for speech is not made. So child becomes mute, but after some time they recover. Then you have got apathy, aphasia, panic syndrome. That is due to the paralimbic connections. Then cerebellar aphasia, as I said, that it is on the right side of the cerebellum, and cerebellum forms part of the broader language network. Classically, language network is perisylvian area. Now there is many areas involved. It's a broader language network, and only thing that verbal fluency, word finding difficulty, agrammatism, reading, writing abnormalities are reported, and it is in the research process much more. Like I showed you a paper of face, emotion recognition is there. So cerebellar aphasia, posterior hemisphere, fluency is affected, meaning, content, sound processing, all this becomes affected in posterior lobe of the cerebellum. And cerebellum and its connection to the frontal lobe reduces attention in cerebellar disease. So I have broadly covered, but I have only given the template. Each one of you should read. Now it will be very easy to understand because I have put everything into one part of the cerebellum and simplified it, but you will have to read it again. And at the bedside, you find out a person with cerebellar disease, what is the age of onset, is there any family history or ethnicity, what is the ethnicity. We have some genotypes are present in some ethnic population only. The mode of onset, acute, subacute, chronic, static, progressive, remitting, relapsing, and then duration of disease, course, how is it, and systems involved. For this, I will request that the students to go back to the old, outdated, modified Greenfield's classification. That is very useful for collecting the systems involved in a given patient. That's very useful. Even though we use the genetic classification, you need not use it to classify, but at the bedside, to categorize, it is very useful. I have discussed such cases with some of the students in the olden classes, and I have elaborated what is this Greenfield's classification. Then what are the systemic features in the patient, and what are all the drugs and toxins the patient is exposed to. We know so many drugs which produce cerebellar dysfunction. Then we have gone through cerebellum, which is vestibulocerebellum. So drunken gait, classical drunken gait with eye signs. Paleocerebellum, I showed only the leg is there, so gait ataxia. Neocerebellum, every other dysfunction of cerebellar disease is there in the neocerebellum. And peduncles, remember, do not produce speech or language abnormality. So when a patient is having speech or language abnormality, even though the other signs of the patients are predominantly brainstem, you have to invoke the neocerebellum. Speech and language will not be affected in peduncle disease. Eye signs typical of cerebellar disease will not be seen in peduncles. So each peduncle has got a group of abnormalities. Superior cerebellar peduncle is upper limb incoordination, and middle cerebellar peduncle is spastic ataxia. Inferior cerebellar peduncle is predominant vestibular symptom and lower limb features. But if the patient has speech and language abnormality or eye signs typical of cerebellar disease, you will have to invoke the hemispheres and cannot be confined to the peduncles. So SARA is a scale for assessing and rating ataxia. Various parameters are there, in which by applying that you can quantify the dysfunction at one point of time. That scale is called SARA, scale for assessing and rating ataxia. There is a large cerebellum in autism, atrophy in schizophrenia. These are all pointers for cognitive functions of cerebellum, but we do not know how exactly atrophy happens, how exactly hypertrophy happens. In these conditions is only a postulate. Specific cerebrocerebellar loops are getting affected because of the cortex and the cerebellar links. We saw that's the second largest organ, the first being frontal lobe. So there is extensive connection with the cortex. So some of these loops may be breaking down, and that may be the role of cerebellar disease in cortical disorders like autism spectrum disorder, schizophrenia, and ADHD. These are mainly cortical syndromes. Why cerebellum becomes dysfunctional? Because of the corticocerebellar connections probably. Then at the bedside, I have told time, age and all, we have to get all those information. The long duration progressive or degenerations, long duration static or static insult, episodic is episodic ataxia, short duration may be vascular demyelination, tumors, trauma, and the parts of the neuraxis which are affected. In addition, are their posterior column, corticospinal tract, and systemic features, what are they? All that if you put into the table at the end of your patient's examination, you will land on the diagnosis. Episodic ataxias may be drugs and toxins, metabolic disorders, heart-nup, urea cycle disorder, pyruvate decarboxylase deficiency, and intermittent branch chain aciduria. These are metabolic disorders. Then autobrewery syndrome, when you have a congenital cell-mediated immune defect, when there is systemic candidiasis. Because of the cell-mediated immune defect, patients will have visceral candidiasis inside the gut. So whenever you take a carbohydrate meal, the candid will act on the carbohydrate and produce alcohol. That alcohol gets absorbed and patient presents with self-produced alcohol syndrome. That is autobrewery syndrome. Intermittent ataxia are linked to carbohydrate meal. Then craniovertebral junction anomalies, arteriovenous malformations, demyelinations, inflammations, and genetic episodic ataxias. Then you record the stature, neck length, look for telangiectasia, cave ring, pingucula, cataract, aniridia, retinitis pigmentosa, optic atrophy, corneal clouding, skin, hair, nail, tongue, teeth, tonsil, and other systems. And this is a tendon xanthoma. Actually, this patient, when was young, repeatedly underwent biopsy of these nodules, but specific information was not given to the pathologist. So CTX was missed. It's a treatable condition. It was some non-specific diagnosis was given. They were resected, symptomatic measures and all given. Later, patient developed cerebellar ataxia and dementia. At that time, the diagnosis was very clear, dentate nucleus signal changes. But this person initially met many people for these nodules. Biopsy was done, but unless you give the instruction to the pathologist what you are looking for, they may not look for the xanthomas. So that was missed. So this is cerebrotendinous xanthomatosis. Importance is if it is diagnosed early, cognitive dysfunction can be prevented. This is a very hairy child. Is a clue for a SERF mutation, mitochondrial disease, ophthalmoplegia with ataxia. This is the MRI of that child showing putaminal hypertension. It's a midline lipoma. Again, a clinical marker in a patient with ataxia, seizures, cognitive dysfunction. This may be mitochondrial disease. And this is MLF showing MS, multiple sclerosis, can present with intermittent ataxia. This is ataxia, telangiectasia, IgA deficiency, copper pigmentation in the teeth and the IKF ring, Wilson's disease, cellular spot, Niemann-Pick's disease. Then you have got the metachromatic granules, metachromatic leukodystrophy, tumors. These are various tumors. Molar tooth sign, Joubert's syndrome. Then hard cross bund sign, MSA. Then you have got putaminal sign, again MSAP. So these are some clues. There is a huge number, I not put all those things. So when they say patient with ataxia, is there a family history? Is there no family history? Then go through all the parameters which I have elaborated now. Most of the time we will land on the diagnosis. So yeah, by the age of onset, this is the table. This you can go through. Again, that's a very important clue. When did the patient's ataxia start? So you can get a probable diagnosis. Then recessive ataxias or younger age group, history of consanguinity, associated peripheral neuropathy, depressed tendon jugs, and other system involvement is a bedside clue. Early age and depressed tendon jugs, not alpha spasticity, where there is a hypotonia with retained reflex, which is seen in SCS. Whereas recessive ataxia, there is depressed jugs due to associated peripheral neuropathy. So recessive ataxia diagnosed when there is family history, younger age peripheral neuropathy, and other system involvement. The progression depends on the nature of the cause of the disease, type of mutation, and repeat size in trinucleated expansion disorders, And other conditions, acute presentations, vascular demyelin, they are all regressive disorders. So these are DNA repair disorders. So many episodic ataxias are there with the telangiectasia I showed. So many types are there. And autosomal dominant, that is late onset cerebellar ataxia, depending on the combination of other features. So I told the clues. So what all things you should record? I gave that PPT, other systems involved. So take all those parameters, fit it. So even though not done the genetics, there is a phenotypic genotypic correlation. So by looking at the phenotype, you may correlate with the genotype. So these are some of the clues for a SCS. So now SCA 1, 2, and 7 have olivo-pontocerebellar type of degeneration. So MRI will have some changes. SCA 2 and 3 have basal ganglia involvement, and additional anterior console is seen in SCA 3, and SCA 7 associated retinal degeneration, SCA 17 global brain atrophy, and SCA all SCAs except SCA 6 have significant brainstem degeneration. Some short clues I have given. So I have gone through. Just I thought I'll put on art related PPT. Nowadays we are hearing about hospitals appointing bouncers. That's a very interesting turning in an aggressive society. Should we go about it, continue that or not? It's young people's responsibility to produce because physical, mental, social and spiritual well-being, and not mere absence of disease or infirmity. So health is defined as physical, mental, social and spiritual well-being, and not mere absence of disease or infirmity. So we have got a responsibility to maintain spiritual and social well-being of the society also by appointing bouncers, which may not be possible. So you have to produce a great transformation. How many bouncers we will employ to prevent patients assaulting doctor and doctor assaulting patient and bouncer assaulting patient? This also, of course, it is there at certain situations when you are abused. We are not trying to do all those things, but this is a very funny turn. But we have got a larger responsibility to society that we have to remember. So bouncers is a joke. So you need true expression of non-violence is compassion. So violence may be from caregivers to doctor or doctor to caregivers. So everything has to change. It's not unidirectional. Like cerebellum is having bidirectional. Everything in the world has got a bidirectional link. So true expression of non-violence is compassion. Compassion of caregivers to doctor, compassion of caregivers to their relative, and doctor to the patient and doctor to the society. So this responsibility we'll have to, somewhere it was lost, it was diluted, so that once very much respected doctor-person patient relationship is now dependent on bouncers. So that should not continue like that. So true expression of non-violence should be promoted by the medical personnel. We are educated people, and of course we can keep bouncers for a short time, but later it should change. So true expression of non-violence is compassion. It is accompanied by a feeling of responsibility. Responsibility is not the technical treatment, because we know that research always is needed. So it's a changing concept. What we treat as a absolute medicine today, 100 years later, it is absurdity. So what really cures is more the faith, and the faith-induced healing process is much more. That the art-induced healing process is much more. I have once spoken on art and science of medicine in the White Army itself. So it is not medicine. If it is medicine that is healing 100%, then why research is needed? Research is not needed. One time you diagnose something, treat something, you be with that. It's not so, because medicine is a different science. So you have to inculcate the feeling of responsibility in the society and the doctor. You have to tell the patients, bystanders, 1 second we can teach them their duties and responsibilities. And we will also be feeling very responsible to the most important thing that we handle in our fellow human beings, that is their life. So to create a society with no selfish or ulterior motives, but affirm in the society a sense of universal responsibility. And we'll start overcoming violence in the society by creating a world slowly, by lighting small candles of responsibility and producing a secure world to live in and not depend on bouncers. So this is also important for the next generation. We are old, we are outdated people, but the young boys and girls should not imagine bouncers is important for medical practice. No, we will create a new world, new changes, so that the world goes back to the old India, which is full of love. No?